Welcome back to the Tomb, everyone. This is Tomb Talks with the Pharaoh. You already know who it is. And for today's episode, it's called A Message from the Sage. And I have a very important guest with me, a reoccurring guest with me, and I'll have him go ahead and reintroduce himself.
Good afternoon. My name is Rueben Warren, and I have worn many hats, but most recently, I've retired from serving as a professor of bioethics and director of the National Center for Bioethics and Research in Healthcare at Tuskegee University. And retirement simply means not stopping, but just doing the same thing in a different place.
Yes, and you were there for 12 years, correct?
12 years.
Okay. And later on, I definitely want to get into the history of how that center came to be and how you ended up there. I wanted to take a second just to pay homage to the title of the episode because one of your colleagues, Dr. Hodge, he would always call you the sage. And you said that you've worn many hats throughout the years. Could you give a brief history of the hats that you've worn and how you've gotten to the position that you are now?
Yes, I think I should start by saying that I am committed to lifelong learning. So the first hat that I wear very proudly is that of a learner. So that's the first. Secondly, after my undergraduate experience, I went to two different undergraduate schools. Actually three. I started at Los Angeles State College at the time. It's now Los Angeles University. And then I transferred after 2 years to Prairie View A&M, which at that time was Prairie View College, now Prairie View A&M University. And then I spent a year there and then transferred back to San Francisco to San Francisco State College at that time, and now at San Francisco State University. And from there, I spent my last 2 years in undergrad and then transferred then to Meharry Medical College in Nashville, Tennessee. I'm a dentist and spent 1968 to 1972 at Meharry Medical College in Nashville, Tennessee, which you surely know is a historic HBCU, a private academic health science center. Spent 4 years there and then went on to do a master's in public health at Harvard School of Public Health in Boston, then a doctorate at Harvard School of Public Health in Boston, then a residency in dental public health at the Harvard School of Dental Medicine, and a fellowship in dental public health. After that journey, I went to teach in Lagos University Teaching Hospital in Lagos, Nigeria. Now, I didn't give you years, but that went to Nigeria in 1975, 76. Came back to teach at Harvard School of Dental Medicine for a year or so, and then transferred to the University of Connecticut Health Science Center in Farmington, Connecticut. Spent some time there, and then went on to become the state dental director for Mississippi. First is not a good thing for me in my life, but I think I was the first Black state dental director in the country, surely the first Black one in Mississippi. Spent 3 years in Mississippi and then on to serve at my alma mater as the dean of the School of Dentistry at Meharry Medical College. 5.5 years, and then left and went as associate director for minority health at the Centers for Disease Control and Prevention in Atlanta. Spent a good time there, learned a little bit, and contributed, I hope, equally as much. Spent 10 years there really at CDC, and then as a part of CDC, the Agency for Toxic Substances and Disease Registry, which dealt specifically with the adverse effects of toxic and hazardous waste on human health. That was an evolution when I began to understand the real adverse impact of the environment. So I spent approximately 10 years there as well. And then on to Tuskegee to direct the National Center for Bioethics Research in Healthcare. And those are some details that we can get into later, but that's the journey. And I actually retired in December of 2022. And again, retiring does not mean stop. This means doing what you do at a different place.
Mm. Well, I think you missed one because you have a master's in divinity as well, correct?
I sure do. My. Those, yeah. What I didn't do is yes, I after spending about 7 years at CDC and ATSDR, at the same time, I understood the quote unquote the intention of the federal government to really look at at religion, as they said, and how that influences and impacts upon health. Well, in fact, the real issue is not religion and religiosity, but faith. And I understood out of my time at the CDC that so much was overwhelming the health of people of color, particularly Black people. And I wasn't trying to understand how we were able to continue in the struggle. How did we hold on? And that took me to the Interdenominational Theological Center there in Atlanta as well, where I simultaneously, as working there as a part of the federal government, as part of CDC, I also pursued a Master in Divinity in Ethics and Theology. Yeah, that's the journey.
Okay. I I know that just because of the amount of times I've had to put the letters after your name. I was like, hang on, we missed the MDiv.
Absolutely. Thank you so much.
So with that journey, you said that you went to Meharry Medical College for dentistry, and then you pursued a master's in public health. What prompted you to get into public health?
What I wanted to become a dentist because I had observed suffering. You know, the way this system works, the health system works, I think throughout the world, is folk they want to keep you alive, but they don't want to necessarily prevent you from suffering. And the lack of oral health, or more importantly, more specifically, trying to combat dental disease, is about suffering. There are instances where people die from oral diseases, particularly cancer, but the normal tooth decay, periodontal disease, you don't die from that necessarily, but you suffer. And I wanted to try to minimize the suffering, to reduce the suffering. I say very candidly that before I got to Meharry, I had two experiences at the dentist, and I have two missing teeth to show for that. That's not what oral health care is about. It's not about taking things away, but it's enhancing what you have. So that led me to really engage in Meharry's mission, and that was to increase the Black health professionals throughout the country, to increase the Black health professionals unapologetically. And in that, I was able to really engage in a lot of community engagement activities, community health things that Meharry has done historically. And what that drove me to understand that the practice of public health, which Meharry has done for so proudly and so well, did not necessarily engage the theory of public health. And I wanted to understand more about that theory. I spent between my junior and senior year in middle school, I spent a summer at Soul City, North Carolina, which was a Black county, in a Black county in Warrenton, North Carolina. And Floyd McKissick, an historical civil rights lawyer, bought the land where his ancestors, his grandparents, were in fact enslaved. And therefore he bought that land and tried to change it in from a place of suffering to a place to flourish. And he called it Soul City, developed that place. And I was there to learn about the health and how to enhance healthcare in rural North Carolina at Soul City. That drove me to understand that health cannot be promoted at the individual level. It's population-based. We suffer not because of our individual behaviors necessarily, but because of the system that impacts upon our health: physical, social, psychological, and spiritual. So I needed to really understand the theory of public health. And that's what drove me from clinical practice one-on-one to more population-based. And even though I practiced dentistry part-time from the time I graduated in 1972 until 2007, off and on, but I know it's important to maintain and to enhance my clinical skills, because people didn't need to suffer. So I've tried to transfer the individual suffering to prevent population suffering. That was the journey, and that's how I got into public health.
And thank you for sharing that, because excuse me, is that you definitely have done that, because I remember you were telling me about the, because you've went in front of Congress before about please help me out. It is mercury in the fillings,
Exactly.
correct?
Exactly.
Could you explain a little bit of, because I did a poor job of it, but you can definitely do it better than I can.
Well, that one of the most common diseases, particularly for children, are dental caries. Unfortunately, that's a preventable disease. But what has happened over the years is that we to solve the problem of dental caries, some people call it rotten teeth. You have to go to a dentist, and they remove the decay and replace it with a material called amalgam. That was the most common material used. A mixture of different metals, but the danger is that 50% of amalgam is mercury, and mercury is a neurotoxin. And what we learned over the years is that neurotoxin continues to emit vapors. So you have a silver filling, which is the one that's most provided, particularly for low-income populations, particularly for Black and brown children. Then that mercury continues to emit. And so we've been engaged over the last several years with eliminating amalgam fillings because of the mercury. And there are adequate and more effective and more safer substitutes. The challenge is that those substitutes cost a little more, but the question is the cost, the financial cost, financial burden, more important than one's human health? And I would argue that it's not. And the evidence is not, quote unquote, there that it's an absolute cause-effect relationship between amalgam and adverse health effects, particularly neurological health effects, but there's ample evidence. And whenever there's ample evidence, there's a precautionary principle that was embraced during the environmental justice movement that says, when in doubt, protect the public's health. And there is doubt about amalgam, but there's enough evidence, ample evidence, that we should eliminate it. And that's happening all over the world. The interesting part for me is in many African countries, they've already eliminated amalgam. So this is an opportunity for, once again, for the continent, the people of African descent, to take the leadership role in protecting human health.
And with that, with the elimination of amalgam, it can kind of serve as a case study where it's just, okay, like over here in the United States, they still use amalgam. Now we can look at what that profile looks like, and then use African countries as a comparison of, okay, when they took that out, what does the profile look like? And from there, would you be able to draw like a causation type of inference from that? Because if they removed it and health increase, would that be sufficient?
No, it won't, because you don't have the kind of infrastructure, the research infrastructure to do that kind of work. Not only are there amalgam being eliminated in certain African countries, but also in other parts of Europe. So it's not just a phenomenon that is in one singular part of the world. So what I'm arguing is that we don't need the science to absolutely determine how to improve human health. We need to do what we think will enhance one's health, and then let the science tell us later on. So I'm not trying to establish a foundation for how human health is improved by the elimination of mercury, but I am saying it's a toxin, a neurotoxin, that's clearly in the literature about the impact of mercury, and the fact that mercury vapors continue to emit when you have amalgam fillings in your mouth. That's evidence enough. So in this way, we don't need the science to validate what we're doing. There's enough evidence to give us some guidance on what we do. And so much of what we do in public health is not necessarily science-based, but it has evidence to suggest a way to go. The science generally follows the what people are actually looking to do.
Mm, okay. And you said that you went to Nigeria and you taught there as well. Uh, could you kind of explain like what you were, well, you were teaching there, but it's like what type of work that you were doing while you were in Nigeria and some of the findings that you
Yeah. If you're in the academy, you're supposed to be engaged in research. You're supposed to be engaged in teaching or education, and you're supposed to be engaged in what they used to call service, but now we've advanced into community engagement. So I went there really to help increase the number of dentists in Nigeria. Lagos had the second dental school on the continent. So I knew that the evidence was not there to support an increase in number of dentists would reduce the dental caries. But I do know that increase in number of dental professionals will help to enhance the oral health by not only as clinicians, but as researchers and as educators. So I went there with a threefold agenda: research, education, and in community engagement. And the research agenda was really around what are some of the traditional methods that are employed on the continent, and in this instance, Nigeria, to reduce, to improve health and prevent disease. And I did some work on the chewing stick. And as you know, in many parts of the continent, there's a traditional chewing stick, and there are medicaments in the chewing stick. And what we're able to do at the University of Ife in Nigeria was to get abstracts from different chewing sticks. And I've had about 20 of them that I brought back from Nigeria. We're going to be look at the chemicals that had an impact on preventing dental caries. That started, I had all the chemicals and all bottled up. But when I came back, somebody actually stole my luggage. And yeah, and my all that material I had and clothes and everything, somewhere between Lagos and New York, got lost. But there's still that opportunity. So that was the research agenda, and the teaching agenda was really to help dental students, Nigerian dental students, and Ghanaian dental students to understand the opportunities available to them to enhance their research ability, their clinical specialist opportunities. And so we're able to develop relationships, and many of those students came to the United States, which traditionally they would go to England to do graduate work. So we had students at Meharry, residents at Meharry, they had residents at Harvard, another University of Hopkins, to do public health master's degrees and other specialty degrees, so they could begin to get those skills and take them back to Lagos. But as you know, that brain drain happens quite a bit on the continent. So some of them went back, but many of them stayed here, and that's your choice. So I'm not criticizing, but that's what happened. So that was the educational opportunity. And then community engagement was for me to learn what's going on the continent. So I had the opportunity to travel to many different parts of Nigeria. We really observed the difference between the East and the West and the North, not only in terms of their health, but in terms of their culture and other behaviors. In northern Nigeria, very heavily Muslim.
yes.
And that was very different than in Lagos, which was Yoruba, and then going to the East,
Yeah, the
different ethnic groups, Igbo and Ibibio. So there was a real difference. So I really understand how those differences in culture really, in some instances, were assets. In other instances, they were deficits. They were battles. So I learned far more than I taught in my time in Nigeria. It was the best experience, in quite frankly, in my career.
Mm. So there are two questions I want to ask you. One, well, two things. One about the brain drain. And I don't know if I've said this to you before, but I honestly think that if one policy that can be implemented to reduce the brain drain is that if the country sponsors the the students to go abroad, like it's understood and written out that you're there for, like, if we send you there for a 4-year college, a degree, then you have to come back here and work for 4 years in the public sector. And that would be like the stipulation of the loan, like the school loan for you to do. Because I know, especially in Nigeria, is that they have it where I believe every citizen has to serve at least 1 year in the military, or do some type of military adjacent like training. So I don't think that's outside the realm of reason to saying if we're going to send you to another country to get an education, you're obligated to bring that back.
Yeah, and it's really called public service, and not necessarily in the military, but in some way public service. But at another level, what do you do? Because that was the policy, that was expectation. What do you do if somebody says, "Okay, I'm not coming"? What do you do? Go and get them and put them in jail? What do you do? That happens in the United States.
Yes, yeah, you go get them.
Yeah, you're gonna come to the United States and get somebody because of a loan defect. That I don't think that'll happen. So then they come back and you're forced to do something they don't want to do. Then that's a contradiction, And so that incentive is there. It's here in the United States. Students get loans and they don't pay them back, and so they're in forfeit. So the trying to force someone to maintain their integrity is real issue, and there ought to be a different way. The incentive to come back is where I think we ought to be working, in opposed to the punishment if you don't, and the incentivizing doctors to come back to their country with some of the barriers that are there becomes a real issue, and that needs to be addressed. It's almost like this problem that's going on now in this country about so many people around the world want to come to the U.S. And I'm not sure it's want to come to the U.S. or fear of what's going on in their home country, and they're rather than coming somewhere, they're leaving somewhere. So maybe the focus should not be on penalty, but encouragement, and that's where I think the energy should be placed.
You're not wrong. You're not wrong. But it's like you said, it's that like the integrity of people. And I'll say this for me, it's frustrating when you see the brain drain, because you're leaving, and if they don't have the infrastructure, they don't have the resources for you, you're leaving somewhere, getting an education, and then building up that country, when you should be taking that and coming back and helping your own. So for me, it's the frustration. So that's probably why I jumped straight to the penalty. Is like, no, we're gonna go get them. But it's, I don't know, and it's not analogous, but when I kind of look at it, it's pretty much what we did over here. They took us from Africa, brought us here to build up this country, and didn't, like, we never went, well, some of us never went back to go and try to help. So I look at that more so on an intellectual level, is that we're now choosing to go and build up someone else's house before we build our own.
Yeah, but in a very pragmatic way, that happens here in this country. Folks come from certain communities, low-income communities, certain kind of communities, cultural communities, and they go and get their formal education in terms of health careers, become health professionals, and don't go back to their home country, their home communities, where the needs are so great. But the incentive to go back is overwhelming. To not to go back. The incentive that prevents you from going back is overwhelming. For example, and I use the dentistry as an example. Students, when I was at Meharry as the dean, students were leaving Meharry owing $300,000, and then they're expected to go into communities where low-income communities, and then provide health care. And And many instances, the people that they're there to serve don't have the money to pay. So they're asked to go back and provide services at a different rate, different costs, and they've got loans that are overwhelming that they got to pay back. So they're unable to even live their lives because they're indentured servants. And so I think there's got to be an incentive to draw people back, in opposed to a penalty for them not coming back.
Okay. And I agree with you. I mean, every
And
time
it's
we
not,
talk,
it's not.
you force me to think a different way. So yes, you are correct. Is that having the incentives is the better option, because when you try to tell people what they can't do, they're most likely going to do that. But if you try to make it seem like it was their choice through incentives, then you'll, it's the old saying, you get more flies with what, honey than vinegar.
Uh-huh.
Yeah.
And the other thing that's really important is that incentives are not necessarily only financial. You know, I practice, I've said, I'm a dentist. I practice in low-income communities all of my career, and the incentives, the rewards that you receive from providing care for folks who really couldn't get it otherwise, is just overwhelming. I mean, I to work with a child, a young lady who doesn't have her front teeth, and to provide those front teeth for her changes her whole life. And to get that, to have that opportunity to provide that service at the one-on-one level is just overwhelming. So there are ways to incentivize, and I think we ought to spend some time figuring those out, in opposed to uh, punishing folks for doing what they maybe have no other choice. They have the right to live their lives the way they choose, and we should not uh, criticize them. We should not devalue them for their choice. Respect their choice.
Yes. And so I'm in the middle with you on that, because I am all about people making their own choices and respecting those choices. But I also understand the relationship between the individual and the community. And I feel like the community has an obligation to the individual, and the individual has an obligation to the community. And I guess maybe trying to tease out where one stops and the other begins.
Yeah. I am because we are. Therefore, we are because I am. That's a philosophical position that, if you really work on that early on, then the choice becomes very, very clear. Uh, but we don't spend time trying to unpack that African proverb. I cannot be all that I can be unless you can be all that you can be. That's a Martin Luther King statement, but it really has meaning. And if you engage young people in the kinds of opportunities, the kind of rewards that come from service, then the choices become less challenging. And I've seen it over and over again. Public health is not a career, a specialty in medicine or dentistry that is financially rewarding as the other kind of benefits. And I see it all the time when you get a feedback from somebody that you help collectively, a community you help collectively, then the benefits are ongoing for everlasting. You know, students that you teach go on to do the things that you think are important, and then they think they're important. Those rewards never cease. And you're an example of one of them.
Thank you. Uh, and I just want to circle back real quick, because there was uh, about the brain drain, and then when people do come back. I wanted to talk to you about the rate of dental caries, and how, with, I guess, with people re-entering the countries that they're from and bringing some of the stuff with them, how does that play into dental caries?
Uh, two things. The habits people form when they go other parts of the world to study, they bring those habits back, and communities begin to mimic them oftentimes. And therefore, I think that's an example of how you're supposed to act, what you're supposed to do once you become quote unquote educated. I can remember going to Nigeria, and I went there with my a suitcase full of dashikis and other things. And I got there, and my colleagues, and do in all respect, had European clothes, suits, three-piece suits, and the sun was burning up. And we would stop for tea at noon every day. So those were some behaviors that they embraced from the countries where they studied, and they brought them back. And sometimes they got misinterpreted by communities. This is a status symbol. So, you know, the appreciation for the things that you bring to a place, as well as the thing you bring back, is critically important. So I when I was in Nigeria, I wore dashikis and I had African dress all the time. It was acceptable, but it wasn't the kind of appreciation that I think some of my colleagues who's trained in the United States and trained in Europe brought back. The symbol of success, the symbol of status, sometimes gets confused with the ability and the willingness to serve.
And I think it was Kenya. I was reading an article a couple years ago. And Kenya, I think it was either on Thursdays or Fridays, like they would have like national like Native Day, where people could go to work and wear like their like native clothing. And that always seemed weird to me, because you're in your own country, but yet you're wearing the garments of someone else. And I feel like that's when people say that, oh, like, it's like, oh, like Kenya won its independence on this day. It's like, but the remnants of the colonialism is still there because of just the way that you dress. Because it's not, I'm sorry.
That's similar. That happens here in the States, you know. You could look at a person and in many ways look at how they're dressing and tell where their philosophy, where their principles are. And I've learned not to pass judgment, accept them where they are, and if they accept you where you are, you know. And that's what it was in Nigeria. I had dashikis, as I said, every day, and that was acceptable. Many of my colleagues and who were Nigerian did the same. Some of them chose to wear suits and ties, but it was all okay. It was a mix and a sense of acceptance that was really rewarding. While as when I got here in the States, I wouldn't go without having a tie on in the academy for a number of reasons. But part of it was just the expectation of how you're supposed to look, how you're supposed to act, and along with your quote unquote professional status. So it's a really difficult challenge, particularly for people who are trying to transcend one status of contribution to another.
Mm-hmm. And I want to say that it's not, for me, it's not necessarily judgment on the people. It is a critique of the philosophy that produces that type of behavior. Whereas, like you said, it's a status symbol that, oh, they're wearing European like clothing, so they must be important, or they must be smart, or they must like, there's something attached to it. And that's where I find my contention with is that just because it's European doesn't mean that it's all these other things attached to it.
That's right. That's right. And what does it mean to be a professional? And what are the behaviors that you're supposed to embrace being a professional? And that becomes a challenge. And that's where people who approach their profession differently give people coming into the profession options. You know, I can remember when I went to dental school, I would never have allowed my hair to look as it looks now. Not the gray, but the braids, the dreads. But that when I came into school, I had a big afro, and they said, "Well, don't do that." But at school, they accepted it because it was a time. So you got to decide, but you have to know what your options are. And all too often, if you're not around people who look like you, who come out of the community from which you come, you don't know how, you don't know what's acceptable. So you assume the behaviors and the appearance of those who are teaching you. And that's why it's so important to have a faculty that reflects the student body in which they're teaching. I don't use this word role model because I don't think it's appropriate. I think you can be an example, but you don't want somebody to model your role. They have to model their role, and you can serve as the example of the options. So I'm not a role model for anybody, but I have examples of things they can choose from as they develop their own career paths.
Well, as much as you say you're not, I think you're a role model to a lot of people.
Okay.
They'll probably listen to this and be like, okay, fine, I'll model his role. But I wanted to talk to you about, well, first, well, I was going to segue into this, because you said that with your divinity, you've studied ethics. And I know that from studying under you about public health ethics. Could you explain what public health ethics is, and then how does that differ from bioethics?
Yeah, you've heard the word embrace the framework of bioethics. I think it's really, really important. What has come in recent years is, in addition to bioethics, not instead of, in addition to bioethics, consider public health ethics. The constructs of bioethics are autonomy, benevolence, and justice. Autonomy means you have the right to make your own choice about your destiny and what you do, and decisions about things that are going to happen to you. Benevolence is simply the intention to do good. And we have to start with hoping that everybody intends to do good, even though we know in many instances that's not true. And lastly is justice. And justice is, in my view, simply fairness, being fair. But if you think about that, that's at the individual level. And the things that happen to people happen at the individual level, yes, but more importantly, at the group and population level, group, community, and population level. So we had to force our thinking beyond the individual, which is benevolence, which is bioethics, to a broader framework called public health ethics. And public health ethics talks about the same things that public health talks about and embraces. That is, looking at populations, and not only looking at population in terms of health, but looking at population in terms of social justice, because health is far more than health care. And that brings us to think about social justice. And with public health ethics, we talk about community engagement. I make my decision in the context of community, whether I do it consciously or not. So in order to understand the individual, you must, in my view, understand his or her context, his or her community, engage the community. That is not quote unquote outreach, but engage them in a human, authentic, respectful interaction. That's community engagement. And then beneficence. The intention to do good is not enough. The doing good in measurable ways is where beneficence comes in. I don't want to know about what you intend to do. We've got a history of people intending to do good, but nothing good came out. So I would argue that we have to talk about measurably beneficence, doing things that are measurable, that are good, not intending to do them, but doing them, which is a different paradigm. And then last and most importantly is social justice. It doesn't happen to me because of me only. It happens to me because of who I am, where I am. And so we've got to frame our engagement in a social justice context. Social justice, in my view, is the same as public health. So we don't say public health, we say public health ethics. We don't say bioethics, we say public health ethics. And so we want to embrace them, not either or, but both and. Not either or, but both and. And where appropriately, use them both.
Yes, and and I guess that goes back to what we were saying about the the individual ends and the community begins, because you need both of those. Because if I go into a hospital and what they see, well, obviously what they see is a Black man, public health ethics would help me from being subjected to certain practices on the front end. And then once I speak with a physician or something like that, the bioethics part comes in from making sure that I don't agree to a procedure that I fully don't understand the ramifications of. Is that like a good example, representation of it?
Yeah. Yeah. For example, when you go into a health facility, the assumption is you've been there before, you have access to health care, or the assumption that you've never been before, you don't have access. If I understand your cultural context, if you're Black, if you're low income, the likelihood that you've been is much less than the likelihood that you've not been. So I've not been is where I start. So this patient, this individual that I want to translate into a patient may not have never been to see a doctor. If I start there, then I have a different set of questions that I start with. And I start with not necessarily answers, but with questions. Have you ever been to see a physician before? What happened? Have you ever been to see a dentist before? What happened? Versus assuming that you've been and starting from there. So I think the framework is critically important. So you start with the context of the individual within his or her community. And if you understand principles of public health, you know, if you're Black, if you're low income, if you're a man, it's less likely that you've engaged the public health, the health system in a way that's meaningful. That's where you start. If you're white, higher income, man or woman, you probably engaged the health care system before. And so you start there. And if you Black, low income, man, your engagement probably wasn't positive. And so you start there. And don't stop there, but that's where you start. And that's the community engagement part of that. That's so often missed.
And you touched on three things out of the seven that during in your class you would say that when performing or conducting public health ethics that you need to consider. Could you quickly list the seven? Because with your Black, it was race, low income, that was income, and then sex with the male or woman. Could you explain the other four?
Let me frame them in a way that I think prioritizes them.
Sorry.
In public health ethics, let's talk about race and ethics. Excuse me, race and ethnicity.
Mm-hmm.
First thing. Second, sex and gender, and they're different.
Mm-hmm.
Third, income, high, low, whatever. Fourth, geography, rural, urban. See, and those are the principles that you start with. And you can look at a person, ask the empowering questions, and that'll help you frame what you're talking about. So that those are the frames that I think are critically important. And of course, age.
Mm-hmm.
You don't start a child that's never been to see a provider is very different than a teenager or an adult or an elder. But the assumption is that if you're an elder, you've been, you may have not been. If you're Black, if you're color, if you're low income, you may have only gone when crisis occurred. So if you have those constructs in your mind as you think through seeing a person, you have a context from which to deal with him or her.
Okay, so it was 5. So I got that question wrong on the test.
Just think about that person: race, ethnicity, sex, gender,
Mm-hmm.
age, income, geographical locale.
Locale. Okay. And with those things is that when you're engaging in the healthcare system, or when you're just engaging in health in general, is that there are certain beliefs that people have behind that is like, I think the example that we talked about one time was, if you're an elder, there's a belief that you're not supposed to have all your teeth, and with that belief, it shapes your health behavior. And so, could you kind of expand upon is the KAP model, and then how that doesn't work in the context of health behavior? Well, there's an additional step before that.
Yeah. But first and most importantly, I think people need to just know that 85% of health has nothing to do with healthcare. So don't think you're going to a healthcare provider to be healthy. You're going to a healthcare provider to promote your health, hopefully, but more often to prevent disease, and more specifically to cure something, to fix something. So the assumption that I'm coming there to be healthy is a false notion. And so that's just a reality. And if you accept that, then you have a different perspective about how to maintain your health. That is, you have to do that. But the assumption when you come there and you go into a health care setting, if you will, the provider all too often says, well, the way I can encourage a certain health behavior or healthcare behavior is to increase the knowledge that this person has. So I want to start off with telling him or her what they need to know to be healthy, and thinking that's going to change what they do. Because the goal in health is to change health education, and health is to maintain, where possible, where positive, your behavior, and change where necessary your behavior. So the notion that I want to change your behavior is a false notion, because you are already doing something good. Otherwise, you would not be as healthy as you are. So let's not start only with knowledge, but you start with knowledge to influence an attitude. So you have to assess the attitude and then seek the knowledge to offset that attitude, because the attitude is going to drive your behavior, not necessarily your knowledge. I think I shared with you in class and others. There was a study done when I was in grad school about the children of ophthalmologists, and their children had more eye disease, more eye problems than the normal group of children who were not ophthalmologist children. Another example is the health behavior of health professionals.
Yeah.
You would assume that physicians are in the best health, and you know better. That dentists have the best oral health, and you know better. So the assumption that your knowledge drives your behavior is a false notion. The fact is, your attitude drives your behavior, and where our energy ought to be focused on what knowledge do I need to know to influence your attitude. And I can get that by understanding your attitude and why you have it. And if I can influence your attitude, I am more likely to influence your behavior. And then I have to look at the circumstances that allow you to enhance your behavior, to shift your behavior. It needs to be shifted. And I have to really talk about those things that you're doing good, as well as those things that you should do better. So let me start with what you're doing good, behavior, and what attitudes reinforce those behaviors. And then I begin to talk about what attitudes do I need to change, and what knowledge do I need to have to change those attitudes. So the KAP model, knowledge, attitude, and behavior, is a false notion. It's start with the behavior. What attitudes do I need to understand about the individual or the group? And what knowledge do I need to understand about those attitudes to hopefully change behavior? Health is a behavior that needs to be promoted and where necessary, change. I hope
Mm.
that uh, was clear. I don't want to be too academic.
Oh no, it's fine. This is, I mean, we can get as academic as you want.
Okay. The
uh,
behavior is where we start. That's different than formal education. Formal education, you're focusing on knowledge. I want to increase your knowledge. In health education, I want to enhance your behavior. Very different goal. Very different goal.
and that's, and it's something that you said that was like with like how people believe like dentists have the best oral health, and how your attitude can influence that. Because I'll let you know right now, if I go to a dentist and they don't have any teeth, I'm leaving that office, because I would look at it as, how am I supposed to trust you if in like with my oral health if you didn't even trust yourself enough to take care of yourself?
Let me even enhance that. If you go to the dentist, look at her or his health.
Mm-hmm.
You see, because it's not about their teeth, it's about their health. But if you go into a healthcare provider's facility service and he or she is looking unhealthy, acting unhealthy, then that should tell you something about what they're going to promote and support related to you. So, you have to live the legacy you want people to follow. And all too often, for a variety of reasons, we don't do that.
And I think that, well, yes, a lot of people are walking contradictions, and I'll be the first one to say it. I am one of them. I studied public health, food deserts, nutrition, everything like that, and for a while I was overweight. I'm getting back down now, but it was a contradiction for me to try to say to people that you need to eat healthier, and I'm overweight myself. And sometimes it's the message can get lost on who the messenger is, and about, can I trust the messenger? And that's something that I wanted to talk to you about, is trust and trustworthiness.
Yeah, all too often, particularly with Black people and other folks who are in oppressive circumstances, is that they've been asked by the systems, health systems, educational systems, economic systems, to trust it. I want to help you, so trust me. And in the context of historical reflection, those systems have not been trustworthy. And so I find it problematic when you're asked over and over again to trust, to trust. And I would shift and say, prove yourself trustworthy. And if trustworthy is realized, then trust will come. And it takes time, it takes intention to prove yourself trustworthy. We intuitively trust people. A child trusts her or his parent until that parent violates that trust. A baby trusts his or her mother until their mother violates that trust. And all too often they trust them again and again and again. So the systems, health systems in particular, ask underserved communities to trust us, trust me, the research community, trust me. And then you've got instances, historical and current, where that trust is violated. And I would argue, don't ask me to trust, prove yourself trustworthy. And you can only prove yourself trustworthy, in my view, with engaging the time, engaging public health ethics. Put in the time before you want something. So when you want something, people understand you care about them, not their disease. Don't come and talk about a research project on cancer when you're trying to prevent cancer or cure cancer in a population. Start with people who are cancer-free and talk about, I'm interested in your well-being. And so if there's an interruption, a violation of that well-being, cancer or other disease, then when I come to you to say, how can I restore to your greatest well-being, your optimal health, if you will. So let's talk about trustworthy, which has to be earned, in opposed to trust. This notion of trust, again, I can give you time and time again, historical, and started in 1619, about where our humanity was violated, uh, and move on to current issues with COVID-19, and show that the systems have not been trustworthy. So let's not talk about trust. Let's talk about prove yourself trustworthy. And I would argue trust will come. An example of the vaccinations. Once the Black community began to engage in a very authentic and transparent way with the health systems, then the vaccination rates increased.
Mhm.
But it took the time and the energy and expertise from people, some who look like the people they want to serve, to prove themselves trustworthy. But it's more than just looking like the people you serve. Prove yourself trustworthy regardless of who you are. And I would argue trustworthy trust will follow.
And from what you said is that prove yourself trustworthy regardless of who you are. I would also expand that just to say regardless of who you interact with, because there can be a community agency, a doctor that is trustworthy with one group of people, but then untrustworthy with the other, and that person still might be like a good person, but they just how they interact with the community is different. And in terms of when you were saying is that there were historical just instances of untrustworthiness, um, I recently just read about with John Hopkins University about the lead study. I never knew about that, where they were pretty much examining the effects of unabated lead on the development of children, and they never told the families, and they were majority Black families that like were living in the apartment buildings, that their children were being exposed to lead, that them and their children were being exposed to lead. And it's it's things like that where when there's a breach of trustworthiness, a person or a community now has trauma that they have to work through, and with that there's a healing process. Um, one of the most notable breaches of untrustworthiness was the USPHS syphilis study at Tuskegee. It's not called the Tuskegee experiment, people. Everyone that's listening, it's not called the Tuskegee experiment. And with COVID, when that happened, people were trying to cite that as the reason why Black people do not want to engage with the medical, with the healthcare system. And could you kind of explain, well, first explain the study, what happened and the implications of it, and then today, what are the residual effects of that?
So this thing that people call the Tuskegee syphilis study, and you're so correct. When you say the Tuskegee experiment, we're really talking about the Tuskegee Airmen. So that's the first thing, and that's a very noteworthy experience. World War II, they didn't think Black people could have the capacity to fly a plane. So
That's where the
they
movie Red
went to,
Tails comes from.
exactly. They went to Tuskegee and piloted uh, a group of Black men, and those Black men called the Tuskegee Airmen showed out and not only were able to do all the things that others could do in a plane, but their success in wartime was phenomenal. So don't talk about the Tuskegee experiment. The original name of the study that occurred, so-called study that occurred in Tuskegee, was the Tuskegee study of untreated syphilis in the Negro male in Macon County, Alabama. Now, that is such a distortion, but it talks about what they really were trying to do. They were focusing on Tuskegee because of the historical relationship between Booker T. Washington and the Black community and the nation. So when you said Tuskegee, it was positive in terms of Black folk. That's why they said it was a Tuskegee study. Negro male. It's not uncommon that there are studies that are specific to populations. Um, but why just the Negro male when Tuskegee was an epidemic at the time in the 30s, in the 40s, across racial lines, across income lines. But they wanted to suggest that it was just Black men, untreated syphilis. That means they never intended to treat this disease. And so they said, well, at the time when syphilis was rampant back in the 30s and 40s, there was no good treatment. In fact, the treatment was sometimes worse than the disease. And so we said, well, okay, so they were
Wouldn't they
not
give them mercury as a was it
part of
mercury?
there you go. There was part of it, yes. So you see the kind of contradiction, but everybody was getting it. So it was horrible. But so
Yes.
what they said, well, we can't use this as a treatment when it's so dangerous. So in the late 40s, when penicillin became available, they said, okay, now we got a treatment for syphilis, but they were intentional about not allowing these men to be treated. They developed what we call in public health a surveillance system, which was to chronicle, to trace disease, disability among populations to prevent further occurrence. And what they did with syphilis was they put these men in a surveillance system wherever they went in the country, and they would not be treated. They would not be treated. So it was a contradiction. And they said it was in Macon County, but the men were all over the country, in fact, in different parts of the world. So it was a contradiction by definition.
And they never told the men that they had syphilis. They called it bad blood, correct?
Yeah, and so it was a lie. You know, and people talked about the coronavirus pandemic. They said, well, it wasn't like this Tuskegee syphilis study, quote unquote, but it was because it was not about withholding treatment with the coronavirus pandemic and giving treatment with the Public Health Service syphilis study, but it was about deception. So don't talk about what the government did or did not do. Talk about the deception. The second thing that was important about that so-called study was that there was a cultural competence that was overwhelming. They went to the church in Macon County and in other counties around Tuskegee to encourage and solicit the men to participate because the Black church was a trusted entity. So as we engage in research now, when they come to these churches, the Black churches, other community churches, to encourage you to participate in clinical trials, then you have to be very thoughtful about why they're doing it. Not that it's bad, not that it's good, but that strategy is not a new one. And then again, I said deception. They simply lied to the men, their families, and they didn't expose the study in 1972. It was exposed by the Associated Press and the New York Times. So it's not like the scientists said, okay, we're now coming to a conclusion that we're doing something wrong and we're going to stop it. No, it was exposed. And in fact, one of the major scientists in the so-called study said, we didn't do anything wrong. The men didn't have anything. If I had to do it again, I'd do it again. So it was never any acknowledgement that they were in ethical violation, both morally and ethically. So that was a horrible instance of now I won't say violating trustworthiness, because historically, the United States has never been trustworthy to Black people. Let's start in 1619 and enslavement of Black people. Let's go on to the early 20s with the eugenics movement, where they simply said, well, there's something genetic, biologically different between income of populations. In Europe, they said income was a major factor. When it got to the United States, it was income and race. So it was another violation of our humanity. So don't start with, we were trustworthy and now we violated the trustworthiness. No. Look at the native population and what the early settlers of this country did to them. Look at what they've done with black people continually. So the question is not to reestablish trustworthiness. Prove yourself trustworthy. And that becomes the challenge of the day. And there are violations today. So we don't have to go back historically. We can talk about the things that are happening today that violate our humanity. And that's where we start, not our health care, but our humanity. If we start there, that's a good starting point. We don't start with health care because we know that that's not served as well as anyway.
And like you said, it's only 15% of our health to start off
That's
with.
right.
So you're
and you're responsible for your health. The doctor's not responsible for your health. You are responsible, and you have to understand that and actually challenge those things that you don't think will promote your health. You know more about your health, about your body than anybody. And what you go, I think, to healthcare providers is to have them share the opportunities to promote your health, to prevent disease, but you have to make the decisions what you will or will not do. Not the doctor. And consult them, listen to them, but you make the decision about your health.
Yes. And with that, I wanted to, first of all, get your thoughts on about like concerning the study, because as you know, with the internet, there's a lot of either conspiracy theories or alternative, I'll say this, alternative history. That's the best way I can describe it. With what happened in the study, a lot of people think that the government injected the men with, or intentionally gave the men syphilis. Is there anything that points to that might have been the case, or was it more so that they went and observed that it sought out men that had syphilis?
Yeah, there's so much conversation about the so-called U.S. Public Health Service syphilis study at Tuskegee that I would not be absolute on anything. But what I will say is the evidence that we've had thus far, the work that's been published thus far, does not suggest that the men were intentionally injected with syphilis in Tuskegee. Let me start there. There's nothing that we can discern that they were intentionally injected with syphilis. However, in 1947, the same scientists from the same agency did inject syphilis in Guatemala to incarcerated people, some children, and for women who were sex workers. So they intentionally injected syphilis. We know that, it's well documented. Same man, same agency. So I can't say they didn't do it in Tuskegee. I can't say they did do it in Tuskegee, but I can say with full confidence that it is possible that the same occurrences did happen. So we've got to be really honest of what we know, what we don't know. And right now, as science evolves, we know that when you take specimen, when you take samples for research, you keep those specimens and those samples. Now, I also know that I've been working with the Voices for Our Fathers Legacy Foundation, which is the family members of the men who were in the U.S. Public Health Service syphilis study at Tuskegee. And they've asked the federal government, NIH and CDC, what happened to the samples? Where are the specimens? And they have yet to get answers. So we don't know where those samples are. We don't know where the specimens are, but we do know they were collected. So that becomes another issue of trustworthiness that we got to continue to pursue. So I can't say yes about what they did. I can't say no, but I can say the evidence that there was no intentional injection of syphilis in Tuskegee, yet the same men, the same agency did intentionally inject folk in Guatemala. So that's a dilemma that you have to wrestle with.
Okay. And with that is with it being, well, first of all, we have the evidence that what happened in Guatemala, it's with that being international, during the time of the study is that they were passing on an international scale ethical like guidelines and laws against like deception on like violation of autonomy and things like that, and it was in direct violation of like what the study did. It was internationally like a crime. And I think a lot of times people don't, they look at it in the context of the United States, where it's just, where people will say, oh, like, yes, that was wrong. That was something that it was unethical. It's like, but we sometimes as African Americans take ourselves out of the global context and don't look at it as that if this was to be done anywhere else, the United States would condemn them and say, this is an international crime. But because it's happening within these borders, it's now it's just, oh, it's something that's just at home.
Yeah. The bioethics violations between 1932, when this so-called study began, and 1972, when the study was exposed, in the United States and abroad, for the Nazi war crimes, on and on and on, the violations of research focused on children, on women, over and over again. And that all happened within the same time that the U.S. Public Health Service CIFA study began and was exposed. So the violation continued in spite of these, and the study continued in spite of the recognition and the halting of other violations throughout the world. So it was a hidden agenda for the study to continue in spite of knowing better. So it was not that we didn't know better, we being the United States health community, research community. What is clear is we did not do better. It was not a bioethics, excuse me, it was not a benevolence violation, because we don't know what the intent was. We can only presume, but it clearly was a beneficence violation. We did not do good, we did harm. And from my perspective, that harm is yet to be rectified, is yet to be justified, and is yet to be resolved. The money that was settled in the lawsuit by attorney Fred Gray Sr. For the families was minimum. How do you pay for suffering? How do you pay for death? How do you pay for dying? So that the ethical dilemma remains both in bioethics and in public health ethics. And it's not that we have to spend our time on apologizing for what happened in the past. What we've got to do is focus our energy on preventing those violations from reoccurring. So let's look back in order to move forward.
Yes. And with that, like you said, is that it wasn't like it wasn't that they didn't know better. And I think that goes back into what we were talking about with the KAP model, is that it was the attitude that they had did not alter, like, in spite of the knowledge that you're signing these documents saying that this is unethical, but the attitude that they had is that we weren't human. And when you said it was a violation of humanity, is that during that study is that they didn't view the men as men, they viewed them as organ systems, correct?
You know, we were talking about how this society viewed people of African descent. And if we were viewed as less than human, then what humans can do to non-humans is very broad. And therefore the notion of humanity versus for the sake of science is a critical question. And what's happened in recent times, particularly with the coronavirus pandemic, it's been said that there's been a not trusting the science. We don't trust the science. And I would argue that it's not the science that's not trusted, it's the scientists. And I think we have to distinguish between the science and those who are doing it. And I think part of what we are challenged with is making the scientists synonymous with the science. And I think we have to look at the scientists as human beings. As I've said many times, you can't be an ethical scientist and being an unethical person. So look beyond the science, and we know that science, at the end of the day, is really science just means to know. And as we know more, but we have to be able to challenge those who are doing the science. So it's not about the science, it's about the scientists.
Okay. And because of how reprehensible and unethical that study is, I don't want to give it any props, but in terms of a surveillance system, they did have they had an impeccable surveillance system, and the documentation of the science was correct. It's just everything that they did with it was wrong.
Exactly. So the methodology was a solid one, except it didn't even adhere to the science. For example, there were no written protocols for the U.S. Public Health Service syphilis study at Tuskegee. There was no written protocols. And how can you do good science without protocols? That means it could not be replicated. So it comes down to the issues of validity and reliability. And we can't replicate that work. And so I would argue that it was not a study, it was a so-called study. And ethical violations overrode the value of what was learned.
Okay. Yeah. Okay. See, every time I say something, you just like to pick it apart, and I can't. And you're right all the time. So
Not all the time. It's just that I've heard the arguments enough to have not necessarily a correct answer, but a response to question the argument, not the person, but the argument. You see, studies started in 1932, so-called study. And by 1936, they knew everything they needed to know.
Yes.
If the original intent of the study was legitimate. So if they wanted to understand the relationship between syphilis and organ systems, they had those answers in 2 to 3 years. By 36, they had the answers. But there's a real question: is what more did they need to know? And they need to collect data to know that. We don't know. That's a question that needs to be answered.
Okay. So I'll stop. I will not make that argument ever again.
Science, the notion of science is simply, the Latin translation is to know. And we continually need to know. The answer is not the most important issue for me in research. The question is, every answer drives a new series of questions.
As it should, because if you stop asking questions, then you, like you said, you don't find out anything else new. My father would always tell me is that if you did not at least learn one thing during the day, then you might as well have stayed in bed. And with that is that you need to keep asking, like you said, the empowering questions of how is it, like, how do you push the needle forward? And especially with ethics is, and you've said this to me before, is that an ethicist doesn't answer questions, they question answers.
That's right. And we ought to be comfortable in our answers being questioned. That's how we grow and not intimidated by that. So it's always a new question.
You do it to me all the time. So yeah. Every time I think I have an answer, it's just, could you define that term, young man? It was just like, I didn't know that I needed to, I wasn't ready to define that term. I thought it was understood, but.
And that's ethics. Understood by who? In what context?
Yes. And we've been using the term ethics a lot. And could you explain the difference between ethics and morality?
Yeah. From my perspective, ethics is what I think is appropriate for me, how I want to be treated. Morals is what I think is appropriate for others, how I treat others. So very distinct. And the contradiction is, in many instances, what I want for me, I don't find it appropriate or acceptable for others. So I see them as different. They don't deserve what I deserve. So that's the challenges. Can we make our ethics and our morals synonymous? And all too often, that's not the question. I wouldn't want that for me, but yet I would allow it for somebody else. Contradiction.
So with that, with ethics, it seems that it's more of the individual versus morality. It's more of the community. It's like how I want the community to be treated. So would it be correct if we use the term ethics, public health, morality?
No, I don't think so, because I think the it's not how I want to be treated is ethics, and how do you expand that to morality? So when you separate the two, then it says, well, I want to be treated a certain way, but I think others should be treated a different way. So from my perspective, when we have when our ethics and our morality intersect, then I think we've got a paradigm worth promoting. When I can say I would want that for me, I would accept that for me, I would not accept that for me, then you've got a really, I think, an opportunity to really act ethically and act morally.
Okay. So how, as a society, how do we get to a standard of, like, where does the standard of ethics and morality come from? And how is it something that is objective, where we can, I guess, scientifically look at it and be like, ethically, this is like how we should be treating people? Or do we get our ethics and morals from something outside of ourselves, being spirituality or religion?
Yeah. I think for me, it is far easier to talk about what is ethically and morally wrong than what is ethically and morally right. So it seems to me that we can agree on what not to do as we explore what we should do. And so the struggle is not to determine what is good for me and not good for you, in my view. It's really to talk about how ought we operate as individuals, in a group, in the community, in a society, and accept the notion that this societal norms are not necessarily accepted or acceptable by everybody. So I think the notion of our collective well-being, I think the notion of community within community, I think culture within culture is what I think is ideal, versus we have one culture, we have one community, and one society, which we don't.
And I agree with you to an extent, where it, like, cultural competency should be taken into account. However, is that I, like, personally, I believe that there is an objective truth to how people should be treated, because culturally is that there, in one culture, is just, it might be culturally okay for violence between partners, and they might not look at it as violence. It's just, they'll look at it as, we're just sorting things out. but in another culture, it's just like any type of violence is wrong. So I guess what I was trying to get to is like, what would be the objective truth that is the underlying thing of all cultures where we can come to common ground?
Without sounding religious, love thy neighbor as thyself.
Mm-hmm.
I think it's a universal truth that I think is both ethically and morally consistent. But how that outpictures, to me, depends on the circumstance. It's almost like this notion of a just war. Is war ever just?
Mm-hmm.
Is both a philosophical and I think theological question. Just war sounds contradictory to me.
Mm-hmm.
So I think, for me, the what not to do is a more doable paradigm than what to do. I think because we get into some debates about what to do, but I think we collectively can agree on what not to do. Do no harm can expand into all levels of violence, be it interpersonal, be it community violence. Do no harm.
Yes, I agree that we should do no harm, and that should be the underlying principle. However, is that when I think about it, is that especially with physicians, it's do no harm, but you'll have instances where you have to break someone's bone to reset it for the greater good. So I guess the question is like, where does do no harm, and then, because I feel like to do no harm, it's more so benevolence, that I'm not intending to do this, and then I guess maybe doing good, or like that outcome is the beneficence of it. If that made sense.
It does, but it seems to me that the process is not the goal. The outcome is the goal, and that you got to mediate the process so that it doesn't become overwhelming. You've heard this, of course, the notion about, well, it's going to hurt a little so you can be better. And so I think the notion is focus on the process. I mean, on the outcome versus the process. So in order to get there, you have to engage at certain things. As a dentist, I used to have to give an injection so they would numb a certain area in a person's mouth. But that the goal was to make them better. And that's the behavior, that the measure of behavior is not that I had to give the injection, but it's that the patient is better. And that's what I should be measured by.
Okay. So it should be do no harm, but also do good, correct?
No, I think that we don't need to do no harm. We need to do good. But then the means cannot justify the end. You remember that? The means that justify the ends. You got to balance that, and to give an injection in order to make a person's health better, is the notion of process is minimized. The process cannot outweigh the outcome.
Okay. And when you said the means shouldn't justify the ends, that sparked a flashback from Indian class. And this will be my second to last question, is that in terms of us as Black people, in the context of philosophy with utilitarianism, because I feel like with public health, that's one of the operating philosophies, is that do the greatest good for the greatest amount. How do we fit in and interact in that using utilitarianism, because we're not the great, like, we're a minority in this country, but not in the world.
It seems to me that you've got to first define who we are. And my definition of who we are people of African descent. And so this whole notion of minority does not exist in the greater context. Now I may have to think globally and act locally. That's okay. But my philosophical position is we are an African people, and so the community in which I define myself is the greater good. And so to do what's in the best interest of Black people is where I find myself. Now, that does not mean at the expense of others. And that's where I think the real moral dilemma is. And you can't, the means does not justify the end. So it's that balance between how do I do what is in the best interest of Black people without doing harm to others. And that's not a dilemma for me.
Mm. Yeah. No, you're 100% right with that, because a lot of times it's that people think that equity, if you're acting in an equitable manner, is that it necessitates that you're taking away from someone else. And we've had this conversation about equity versus equality, and I would say that equity over a certain time period leads to equality, but the reverse is not true.
I would agree, but it does also raise the question about the notion of lack. There is enough in the universe that will provide for everyone in the universe if it is equitably shared. The problem is when there is greed and exploitation, then it's inequity. So, if you started with the notion there's not enough room, there are not enough resources, then you have to determine who gets and who does not get. But if you take the position that I do, that the universe is bountiful and there is enough for all to live in an equitable way, then the challenge becomes, how do we assure that? Not starting from the point there's not enough, and so somebody has to lose. Win-win.
Starting from the deficit model.
Exactly. Win-win is the position that I find myself believing very much in, not win-lose. And there's not enough. The deficit model doesn't work for me.
Yes, because when people have to operate in a mindset of scarcity, then that's where you see a person's humanity start to break down. In my opinion, is that because if resources are scarce, I can't afford to look at you as a brother. I look at you as competition now. Mm-hmm. And that's hard.
The other thing that's important about that is that greed has to be considered. Even if there's enough, if I want more than my share, my fair share, then I tend to take from you in order that I have more than I need, in opposed to what I need.
Yes. Yeah. Because there are some people with, just speaking in terms of finances, that even if they lived for 200 years, they couldn't spend all their money.
There's never enough.
Yes. And I want to close out with talking, this whole thing is about health, but it was something that you taught me, is about health disparities, because especially with COVID and everything happening, is that became a very big buzzword, is health disparities. And people think that the way to solve health disparities is to pretty much have the rates of, well, health disparities in and of itself is the difference between uh, racial, age, sex, and gender groups of like the established norm. And in the context of Black people, is that we with our health disparities, it is compared to white people. And there are two ways in which health disparities can get better. It's either we become healthier or they become sicker. And how do we frame this in a different way so that the context of our health, the way that we look at health is not related to how sick white people are?
Yeah, two things. One, the disparities, health disparities are based upon privilege, hierarchy, and wealth.
Mm-hmm.
I think Scholar Braveman wrote that, and I agree. And so rather than dealing with health disparities, we've got to fundamentally, and as a goal, deal with privilege, hierarchy, and wealth. And in an equitable society, there should be some balance with those three dynamics so that you can't define privilege, hierarchy, and wealth based upon race, ethnicity, sex, gender, age, income, or geographical locale. So if the goal is to develop a society where that all have what they need, then it's going to demand a redistribution of resources. And you don't start from the point of a redistribution of resources, start from the point of when resources were inappropriately divided.
Mm-hmm.
And for the context, from my perspective as an African American, we start with 1619, and how from that point over there was never a sense of equity, never intention for Black people even to be perceived as human. So I think we got to back into what it is that we as a people need, and by that I mean people of African descent, and how do we meet those needs given the resources, both physical, intellectual, social, psychological, and spiritual resources that we have. And that's not based upon anybody else. It's based upon how we define ourselves as a group of people. And the work that needs to be done is what do we need, and how do we balance that need based upon the resources that we have access to.
Mm-hmm.
Not compared to anybody else, but compared to our own group.
Yes, because with that, I've said to people when I've explained health disparities is that I don't want to be just as sick as a white person. I want to be healthy. And like, I want my people to be healthy, just not as sick as this person. And I think we talked about it on the last episode that you were on, is that you posed the questions that who told you had to be sick? And I use that going forward. And I guess with all of the experience that you've had and all of the great work that you've done, I've looked at your resume. It's almost 7 pages of just a lot of publications, speaking. It's a lot. Looking back on it, is there anything that you would do differently, and what would you say would be like one of your top achievements?
I would do nothing differently because I don't know what that difference would have done to influence the next step I took. So I think all the steps are divinely ordered. And what I tried to do is work within the context of where those steps have led me. So I'm convinced that there are no happenstance. Things are done in perfect order, and I have to align myself with that order. Um, and what my greatest I don't know if accomplishment is the right word. My greatest happiness is to uh, uh, take the baton that was given to me by giants, mostly Black, and pass that baton to the next generation, which I've tried to do with my career, grounded in education. Uh, and what I'm also convinced of is that when the student is ready, the teacher will appear. So I don't look for students. Uh, what I do is wait for students, uh, and they appear both within the academic context and outside. So I have no uh, fears, second thoughts about the future, because the future is now, and the now that I see is extremely encouraging. Not with the circumstances, the experience, because experiences things that can be changed, but with the foundation of the human consciousness, particularly among people of African descent. So what I am absolutely convinced. I have no hopes for the future. I am absolutely uh, assured that the future is good, because the future is now. And as I've learned from your generation, the notion of it's all good, and
Mm,
I'm convinced that is not good, it's just a not so good experience that we have the capacity to change.
mm. Thank you. I don't think I can follow that up with anything. But
Yeah.
I will
Not,
try.
let me say it clearly, the experience is not the person, and you
Mm,
can change the experience, not try to change the person, change the experience that that person is going through or as being exposed to, and then that will allow that person to see differently if they so choose, think differently if they so choose, and act differently if they so choose.
well, you heard it from the sage, guys. And I'm a very big proponent of giving people their flowers while they can still smell them. And I just want to take a time to say thank you for, first of all, the impact that you've had on my life, the teachings and everything that you've bestowed upon me, and then also the work that you've done for our people. And there's a term that I will pull up real quick because I do not want to get it wrong. Boop, 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 boop. Bear with me, people. Do, do, do. So there's a term that I've always called you, but for or put out on the air, it's called a jegna, and it is a translation from an ancient translation from the ancient kingdom of Abyssinian. In the African culture, a jegna is a title of distinction. The word has been translated into English as to meaning hero, warrior, soldier, courage, strength, and protection of our culture, land, and people, and an elder. So you are the embodiment of a jegna. And with that, I just want to ask you one last thing is that for the people that are coming behind you that you are passing the baton to, what advice would you give them so that they don't burn out and they keep pushing forward?
Take time to reflect. Take time to do and reflect. And that which you reflect on will guide you to the next thing that you should be doing. Take time to reflect.
Thank you. And is there anything that you would want people to know? Like, is there anything coming up that you're doing? Anything? This is a shameless plug segment. It's like let them know what's next. I know you're retired.
I think I said in the beginning that retirement for me is to do what I've done in a different place. So the work that I'm doing already begun is a continuation of the work that I've been doing for the last 50 years. So I'm encouraged, and I'm busy, and I'm working on translating that busyness into productivity, and it's coming. There are models of African American men and women that continue their work long past 77. That's my age, well into their 80s, and not so much of what they're doing, but it's what they share about what they're doing, and that's what I'm in the midst of doing right now. And I couldn't be more pleased with this conversation and the work that you're doing.
Thank you. I mean, it's driven by many of the things that you taught me. So you taught me how to argue someone. Well, I just want to say thank you again for accepting to sit down. Again, I know I keep asking you to come back and talk about things, but I know you have a lot to share. So I just want to say thank you again for sitting down and giving us some wisdom, because every time I talk to you, I always learn something.
As I do with you. So we're learning from each other.
Yes. I think you teach me more than I teach you, but we're not going to quantify it. We're just going to qualify it. So everyone, that has been another episode of Tomb Talks with the Pharaoh, and I'll see everyone next week. Peace.